When I'm treating cancer patients with mental illness, I like to help them think of their mind as healing at the same time their body is healing, because they go hand in hand. Just a simple can be helpful both to the nurse and the patient. A lot of them are intuitive. They have kind of a high emotional IQ. A lot of patients that I treat kind of know when I have an off day, and they'll say, "How are you doing? Something going on?" But I do try to make the sessions about them and not me. A lot of the mental health patients have had terrible childhoods and traumas that may manifest as odd or angry behavior. But overall, I hope that people can take away that, cancer patients who might have pre-existing mental illness, we can take care of them and they can have good outcomes.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Barb Henry, board-certified psychiatric mental health clinical nurse specialist with a focus on psycho-oncology and member of the Cincinnati Tri-State ONS chapter, to discuss patients with cancer who have a concurrent psychiatric diagnosis and ways for oncology nurses to coordinate care to manage this unique population. Barb presented on this topic at the 2021 ONS Congress. Thanks for joining me today, Barb.
Hi, Stephanie. I'm glad to be here. Hello to everybody listening today.
So, Barb, to start us off, can you please share your experience working with patients with psychiatric disorders and cancer?
Sure. I'm fortunate to have worked on a bone marrow transplant unit and with a large oncology outpatient group for 7 years. During that time, I learned a lot about working with cancer survivors. That oncology group still refers a lot of patients to me for counseling and psychotropic medications. So, about a third of my caseload in my private psych practice consists of cancer survivors. So I found that dealing with cancer can cause depression and anxiety in anyone, not just patients with a pre-existing psych diagnosis. For patients who maybe have experienced depression or anxiety in the past, cancer diagnosis and the treatment often exacerbates the illness. So their meds might need to be changed or dosages increased. Also, since cancer is a life-threatening illness and treatment is so traumatic, our patients experience it as a major life trauma. So patients with previous post-traumatic stress from death of a loved one, divorce, or childhood abuse will most likely experience an increase in those symptoms. And then there are patients with personality disorders who tend to act out their fears and anxiety, and they can be difficult to deal with. So it helps to have a psychiatric professional available to oncology professionals. So those are some of the main issues that survivors are dealing with in my practice, as well as fear of recurrence and death. So at times, I'm helping them work through end of life issues, but more often in my practice, we work on survivorship issues or issues not even related to their cancer.
Well, thanks. I think that, it's interesting, just this whole topic, because you're right. As oncology clinicians, we start seeing the patient because of that oncology diagnosis, and thinking, that's where our focus is on how we're going to care for them and, get them through this diagnosis and just, their whole journey. But the reality is probably a significant number, or a large portion of patients may come with a psychiatric diagnosis already. And so, like you're saying, it definitely, the cancer diagnosis can exacerbate. So, it's going to be really important for oncology nurses to understand how to best serve this population. And I'm excited about our talk today.
Yeah, I agree. A lot of people have addiction or mental health issues, whether they're treated or untreated. So, I think oncology nurses keep in mind the mental state of the people that they're talking to and use good assessment skills to know maybe when someone needs a little extra nurturing and attention. So that's true.
Great. So you talked about, or you mentioned in that, first question that I asked you about some of the different disorders or diagnosis that you've dealt with patients. Can you define for us psychiatric disorder and psychotic episodes? What the nurses need to consider when caring for patients, whether it's a psychiatric disorder or a psychotic episode, and just how that works with cancer patients or comparing them to other patient populations.
Sure. So there are really four main types of psychiatric disorder: mood disorders like depression or bipolar disorder. And then we have anxiety disorders that include post traumatic stress, obsessive compulsive disorder, panic disorders, generalized anxiety. And then we have psychotic disorders like schizophrenia or schizoaffective disorders. And then the fourth category would be substance abuse or addiction, drug abuse or alcohol abuse and addiction. So psychotic episodes can occur in anyone, even if they don't have a psychiatric disorder, but they're more often seen in schizophrenia and schizoaffective disorder. But for patients with anxiety and depression, when they're under extreme stress, like dealing with cancer, they can actually become psychotic. The level of their anxiety or depression can be so high that they just are not in touch with reality and can't focus. The other times that we see psychosis is for people on steroids, and I'm sure oncology nurses listening have experienced that. So basically, oncology nurses probably just need to spend a little more time, have a little more patience, try to build rapport with patients who have emotional distress, and just be present and listen to them. Use techniques to lower their anxiety. We have to remember to take deep breaths and we can breathe with them. Just a simple can be helpful both to the nurse and the patient. In the Congress presentation, a lot of questions came up about personality disorders, specifically borderline personality, those patients that split staff, pin one against the other, have manipulative behaviors, or they can be extra demanding. So, nurses do need to set limits on that type of behavior. You have to balance the limits with maintaining that therapeutic relationship. So I do think that most oncology nurses that I worked with really have good psychiatric nursing skills, even though they don't know it. A lot of them said, I hated my psych rotation. But in delivering care in oncology or med surg setting, all nurses use their psych skills. So it's just a matter of having a lot of patience and using your listening skills.
Well, I have to agree with what some people have said, that I really, really did not enjoy my psychiatric nursing rotation in school, and thought, oh, I would never, ever, ever be able to do that. And I'm so thankful for people like you who, that is your passion and you do so well. But you're so right. We do use those things that we learned, and we do use, that psychiatric part of nursing in our everyday caring for patients. So that's a really good point. But let's talk about the history of psychiatric care and how caring for this population has evolved, because definitely I would say that there has been a stigma related to this patient population. And I dare say that there is still a stigma to, a point with mental health. And we've seen that a lot, even in just news and things like that in recent times. But how has this evolved, the care for these folks?
There is definitely a stigma to seeking psychiatric care or identifying yourself as someone with mental illness. Recently, celebrities are coming out with their mental health issues, which helps people, say, hey, if Demi Lovato can get treatment, I can talk to a psychiatrist or a psych nurse practitioner. But as far as the history, that's part of why, psychiatry has been looked upon negatively. Our history is rather barbaric. In ancient times, people thought psych illness was associated with evil or being possessed. And during the Renaissance age, women with mental illness were actually killed for being witches. This progressed to beliefs that psych illnesses were caused by too much bile or bodily fluids. So, treatments like surgical removal of body parts, lobotomies, bleeding, insulin shock, ice cold baths were unfortunately used back then. More recently, modern psych theorists and treatments were brought to light by people like Freud or Adler, Karen Horney. You might remember these names from your psychology classes. Eric Erickson, who helps us understand developmental phases of childhood, teen years, and adulthood. So, since that time, we no longer do lobotomies in psychiatry. We don't use cold baths or put people in cages, although there are times people with severe psychosis require physical restraint. We do still use electroconvulsive treatments, which are portrayed in movies as rather barbaric. If you watch One Flew Over the Cuckoo's Nest, it's not like that at all. People are put to sleep before the electric shock is delivered. And we're developing more modern treatments for treatment-resistant depression other than ECT, like TMS, which is transmagnetic stimulation, using magnetic coils to send a signal through the brain to rewire it rather than the electric signal. So some of these things in our history have sort of added to the stigma, but it's something that we're trying to overcome and be more humanistic in treatment of people with mental illness.
Okay. Thank you for explaining some of that to us. I think that's really helpful for us to know, and definitely good to hear, just how that is evolving and how it's changing. And like you said, with even celebrities, being open about issues that they are having, I think you're right. It is making people more comfortable and maybe recognizing that it's okay to get help and, where they need it. What are some of the barriers to care that patients with psychiatric disorders and cancer face? And how can oncology nurses help patients overcome them?
Like I said before, a lot of patients with mental health issues can be difficult to deal with because their fear and anxiety is so intense. So, again, we talked about the stigma of psych patients. When you're working with patients who have mental illness, you want to be careful not to judge them. A lot of nurses themselves have depression or anxiety, so seeking treatment for our own mental health issues helps us deal with other patients. Just for an example, one of my patients today asked me to intervene with her primary care doctor, who would not allow her patient advocate to come to appointments with her as her support person, which I think is not appropriate. So I talked to the primary and let him know, this patient is very scared and anxious, and the support person is just there to speak for her. So, when you're working with someone with mental illness, they may have a family member or a friend with them who can give you cues as to maybe how to approach this person so that you're building rapport rather than making them more anxious. So again, nurses, just need to listen to the patients or the family members and figure out how to build a relationship, how to teach them and go about procedures without adding to their anxiety. It also helps to have social workers and psychologists or psych NPs and psychiatrists involved in the case so that the communication issues can be resolved.
That's good. I think it's really important, like you said, to make sure that we are aware of what those patients' needs are. And if that is something like you gave the example of having an advocate with them, so many rural settings don't have things like social work and or something like that available to those patients for small clinics or physician offices and things like that. And the nurses need to recognize or identify if these patients need to have someone with them to help with their anxiety, or just like you said, that being that advocate and speaking for them, and knowing the things that the patient might talk to them about but wouldn't feel comfortable talking to the medical staff about. So it's really important, I think, for us as clinicians to be aware of all of that. And probably, with everything this last year with the pandemic and not being able to have, someone coming into an appointment with you was probably really difficult on a lot of these folks. And if there were ways to utilize telemedicine to be able to make sure that they could incorporate and include that advocate or support person, was probably so important for these folks.
True, and I think the pandemic really escalated mental illness. The good thing that came out of it is the telehealth and the video visits that we can do, so we can at least do a visual assessment while we're talking to patients. Sometimes we just do telehealth with the phone only because they don't have capability of getting on video, so those visits are less effective. But I think too, when I was presenting at Congress, I mentioned people with mental health issues. Sometimes they're just a little quirky. They're not that different from us. We have to just kind of get used to the quirkiness. Or there might be, cultural issues, like you mentioned, people from rural areas, think of their physical and mental health differently. A lot of them have had generations of people who had nerve problems and took a lot of anxiety medication, which isn't the best thing. So there's a lot of factors to keep in mind.
Yeah, that you're it is really important. And I agree with you. I'm glad that there have been, some of those positives that have come out of the pandemic to, help this all patients, but particularly the group that we're talking about right now. So you mentioned in that last comment about social work, let's say. What is the importance of interprofessional collaboration with this population? Whether it is social work, or it would be, someone like you who counsels and focuses specifically on, psycho-oncology and things like that and these patients. But can you talk about that interprofessional collaboration?
Sure. I think any of the nurses who work inpatient know the importance of social workers as far as discharge planning and getting to know the family needs and the patient needs. But as far as patients that you see, outpatient or inpatient, cancer patients that have psych diagnosis and psych professionals involved, it's very helpful for the oncology team and the psych team to collaborate. Patients may be on medications that seem odd, and you might think about changing them, but sometimes those medications are the only ones that work. And a lot of times they're on high doses of medications, but it's very harmful to change medications for a patient who's been on something for years. As I mentioned, a lot of patients unfortunately end up on benzos for a lot of years. And generally, we think of benzos for short term use, but in these patients, it's really more harmful to try to decrease or stop that medication sometimes than just maybe a very slow taper. So these are the things that the psych and the oncology team members talk about. And I think when I worked on the bone marrow transplant unit, I sat in on the clinical rounds and gave my input, as much as the nurse clinicians did on the status of the patient's mental health. And the oncologists really respected that, which was helpful. I think there have been oncology professionals who kind of poo-poo what the psych person has to say, and that's not helpful because we have to work together really to, help both parts of the patient achieve the best health that's possible.
Yeah, I agree with that. So we've talked a lot about, how we work with this patient population, identify patients and help to support them. But, with oncology and oncology diagnosis, there are strong drugs and treatments that they will be getting for their cancer diagnosis. So now let's talk a little bit about how nurses can navigate or mitigate drug to drug interactions with patients on psychiatric or psychosis medications who are undergoing cancer treatment. You mentioned that just a little bit, in that collaboration point, but how can you just talk about that a little bit more?
Yeah, there's a lot of different side effects and drug interactions that come with psychotropic medications. One example are, breast cancer survivors that are on tamoxifen shouldn't take drugs like Prozac or Paxil because they inhibit cytochrome P2D6, which is needed in order for tamoxifen to work. And there's some other interactions like that that we don't think about until, we see something going on with the patient and try to figure out what that is. So I use online Hippocrates, which is a website to look up drugs, dosing, and interactions, and that's very helpful. Also, it helps to have a good pharmacist on the team. When I worked on the BMT unit, we had pharmacists who did rounds with us as well so that they could talk about the different drug interactions that might happen. Another side effect that can pop up, just with a psych med alone, there are antidepressants that can cause SIADH, which is syndrome of inappropriate antidiuretic hormone secretion. And that causes low sodium, which can cause patients to go to the bathroom a lot. And when their sodium is low, they can get real confused and combative, can cause nausea, vomiting, irritability, a change in personality. So that's come up a few times for me with older patients who are on antidepressants. And so for older folks, we have to use lower doses of psych meds. There's also tardive dyskinesia, which you see the commercials for Ingrezza and Austedo, drugs that help with permanent movement disorders. Those can develop for patients who've been on the older antipsychotics for years. So you might see some of those side effects, not necessarily drug-drug interactions, but there are a lot of concerns with psych meds that you need to be aware of. People on lithium or Depakote for bipolar have to get blood levels so that their level doesn't go too high and they become toxic. So there's a lot of little drug interactions and side effects that we might not be aware of, but we can search out information on, when we see somebody on those medications.
That's really helpful. I think that, when we're working with our patients, we need to, again, like I said at the beginning, we're so focused on that oncology diagnosis, but when they do have a dual diagnosis, we need to make sure that we understand that there are going to be other things that we're going to have to kind of keep our eyes open for.
For sure.
Yep. So many of our patients with cancer can struggle with, other mental health issues. You did mention earlier depression and anxiety. With that in mind, how can mental health status influence clinical outcomes?
Good question. So sometimes people who have depression, anxiety, or other mental health issues, they have kind of a negative outlook on life. So they can be pessimistic. In psychiatry and therapy, we try to reframe patients' thoughts to help them become more positive and hopeful. Also, we wonder, do patients with mental illness have worse outcomes when they have cancer? Do they have increased mortality or morbidity? So there was a meta-analysis of data done in 2019 that did find there was a significant increase of cancer incidence in patients with depression and anxiety. People with psychological distress were It was related to higher mortality in cancer patients as well. Other studies have not found such an association. It's, hard to control all the extraneous variables in those studies. So mental illness may increase their risk of getting cancer and they may have worse outcome. But when we're dealing with patients with these illnesses, we don't want to shame them or say, "Oh yeah, your anxiety caused your cancer." When I'm treating cancer patients with mental illness, I like to help them think of their mind is healing at the same time their body is healing because they go hand in hand. We try not to bring out the fact that there may be a causative factor because patients with cancer already feel like they should have done something or they should have caught it earlier. So yeah, it's true that mental illness can affect physical illness, so we have to treat both.
Good, good thoughts. Let's talk about the nurses who work, with this patient population. Why is self-care important for these nurses?
So I'm sure anyone listening today can probably answer that question. It's very easy to become burnout when taking care of patients because when we care for others, we tend to neglect our own self care. And I think that's especially true for nurses working with patients who have a life threatening disease. We develop strong relationships with the patients because we tend to work with them over time. Oftentimes, we get close to them emotionally because they remind us of a family member or a friend, and we really, care about them. And that phenomenon is called countertransference in psychiatry, which is important for healing. And in the same respect, we might remind them of their mother or a caregiver or a friend, and that's transference. So, because the relationships in oncology are so intense, we need to develop self care habits. Whether you do yoga or just do the deep breaths, I like to take 3 deep breaths in my car on the way to work and on the way home. And that way I leave work behind. I don't think about patients when I'm home. It would be easy to do that, and sometimes we all do that, but it's important to have good boundaries between work and home life and a good life balance. So we also need to be careful not to overeat or overdrink alcohol as a way of, feeding ourselves because we become so drained when we care for people that much. You can practice mindfulness, which is simply just living in the moment, giving our all at work, but then leaving work behind and being mindful of what's going on at home. Sometimes that's easier said than done. There was one study I looked at of 50,000 nurses who left nursing, and that study found that 31.5% left the profession because of burnout. And burnout, you might hear it referred to as compassion fatigue, since caring for others takes away from caring for ourselves, as I said before. So, seeking out therapy and help for our own mental health issues or distress is important. There was an NIH study of burnout and compassion fatigue in 100 oncology nurses that came up with the following solutions for caregiver burden. Sleep enhancing practices should be promoted among nurses, and a lot of us stay up till the wee hours to get everything done at home. We need to watch our caffeine intake. The study suggested that night shifts be scheduled in a reasonable pattern, shorter durations, and even offering naps during night shift. I know some units have quiet rooms for nurses just to go in and shut their eyes and relax and not have a lot of stimulation. The article also suggested that administration establish a supportive climate on the unit, provide physical exercise services like yoga classes. I know we had that at Jewish Hospital where I worked, which was wonderful. Right after work, we'd go to a yoga class. Also, hospitals and clinics need to have healthy eating facilities if possible. And that the article also suggested that childcare and parent old age care, daycare, and night services would be offered for nurses with manageable fees. So those are some of the things that clinics and hospitals should look at to help nurses with self-care. and for retention purposes as well.
Yeah, those are all really good points. I think that, we as caregivers sometimes tend to, put that ourselves last and behind us. And, you pointed out a couple of really good studies of nurses and oncology nurses specifically that have left oncology patient care because of burnout, and just how very important it is for us to make sure that we're keeping that in mind and taking care of ourselves as well. So, what additional training or education do oncology nurses need to manage and support psychiatric patients with cancer?
I think seeking out educational offerings like this one can be helpful. I saw that there's another psych nurse practitioner presenting on the topic at the Bridge conference coming up. I noticed that every ONS journal seems to have at least one article with CEUs available on managing psych issues in oncology patients or different psych issues that come up in oncology. So I think workshops and just talking to other team members, getting support, like how do you deal with this patient? Team conferences can be helpful.
Okay. So, another question for you. What does the future of patient care and medicine look like?
Some of the future psych treatments that we're coming up with seem a little radical as well. Not invasive like the ones from our history, but recently we're using a lot of ketamine treatments for treatment resistant depression. So patients come in for a series of ketamine infusions. And as you probably know, ketamine is just an anesthesia. And it has some healing benefit when patients do a series of treatment. Ketamine also comes in a nasal spray. So patients go and get these treatments. They're observed by psych staff after the treatments until they're fully alert. And somehow these treatments sort of alleviate the depression. We're not quite sure how, but there is data that the ketamine treatments are helpful. There's other studies looking at MDMA, which is known as the street drug ecstasy, also for treating depression. Other studies are looking at psilocybin. I'm not sure how to pronounce it. Psilocybin or mushrooms is the street name for that drug to help with depression and post-traumatic stress. So when patients have sort of a hallucinatory type experience with these drugs, hopefully it's a positive one, but something about that experience provides relief or catharsis. And it sounds strange, but preliminary data is looking good. Another treatment that I talked about at the Congress presentation is one that was used for centuries by natives of Peru, Brazil, Colombia, and Ecuador. It's called ayahuasca, spelled Ayahuasca, ayahuasca, which is found to have healing effects on psychological trauma. It's actually a liquid potion that's made from plants that contain dimethyltryptamine. Again, it causes some sort of cathartic experience when clients drink it. Some of these more bizarre treatments are being studied and looking like they might be helpful in the future.
Well, thank you. It is good to see that even, in this area, well, in any area of medicine, that we are just continuing to study and see better ways that we can help our patients through whatever they are experiencing, and just that, we continue to learn. But Barb, you have really given us so much information today, and it's a pleasure always talking with you about psychiatric care for patients with cancer, and just your passion and that you have for this patient group is always evident. And I like to finish all of our podcast with 3 questions for our guest, and I'm going to start those with you now before we finish up for the day. So, first of all, what are some common misconceptions about patients with psychiatric disorders and cancer?
So I think one misconception we talked about a little bit is that, psych patients are scary or threatening, and that's not true. People with mental illness can look like your next door neighbor. You may not even notice any quirkiness. So you approach them as you would any patient. Use your listening skills, your empathy, and good communication. Also, we talked about how people feel like their mental illness or their habits like smoking, alcohol, drug abuse, eating unhealthy foods, which may be all they can afford, contributes to them getting cancer. So, we don't want to judge them. We don't want to perpetuate that myth. Other misconceptions about mental illness, depression, are that, people just need to suck it up, and get off the couch. Well, we know there's chemical changes that happen with depression and, genetic factors. So it's not that people with depression are lazy or just need to get up and move. It's a true illness, just like cancer. I think we talked about, that psych patients may be difficult to deal with, but you can always find a positive in any person. You find a way to connect with them. Many of them are very interesting. They've had interesting lives, and a lot of them are intuitive. They have kind of a high emotional IQ. A lot of patients that I treat kind of know when I have an off day, and they'll say, "How are you doing? Something going on?" But I do try to make the sessions about them and not me. But overall, I think misconceptions are that they're difficult, and we really just have to find a way to connect with people who have mental illness by being ourselves, not treating them any differently than we treat easier patients. We use humor, sharing our own thoughts and feelings to help patients with mental illness make the best of it.
Okay. Next question. What's something about patients with a psychiatric disorder and cancer that's not often discussed, but you wish people knew more about?
I wish people would understand that patients with mental illness are not dumb or, can't pick up on the little things, because they do, as I mentioned in that previous example. They're not often violent or out of control. We might, fear that. Sometimes it does happen, and when those situations arise, we need to use our training, calming techniques, soft voice to de escalate and keep patients safe. Again, when I worked on the BMT unit, a lot of the oncologists would sort of dread going into the rooms with patients who have mental illness, because they might be quirky and talk a lot and keep them in there. So I would just try to help bridge the communication gap and, help the relationship between the patient and the oncologist. A lot of the mental health patients have had terrible childhoods and traumas that may manifest as odd or angry behavior. So sometimes we do have to deal with crisis management. But overall, I hope that people can take away that, cancer patients who might have pre-existing mental illness, we can take care of them and they can have good outcomes.
Great. And last, what are some resources for patients and providers?
I think probably the best resource is the National Alliance for Mental Illness, or NAMI, NAMI. It's a good resource for patients, family members, and caregivers for people with mental illness. It explains all the different mental illnesses and treatments, medications. Their website is NAMI.org, NAMI.org. And then most of you are probably utilizing the cancer support community or other communities similar, like Cancer Family Care, Gilda's Club, so that cancer survivors have a place to take classes and get together with other survivors, not necessarily to talk about cancer, but just to get on with life and developing healthy lifestyle.
Thank you. Well, as I said, Barb, this has been a real pleasure to have this conversation with you today, and a lot of great information that I am sure our listeners are going to use and be able to put into their practice or help with self care. As you pointed out, it's so important for our nurses to do that as well. Before we finish up today, do you have any final comments?
I would like to thank ONS for the opportunity to share some of this information about mental health. I think one of the takeaways is that all nurses have psych skills, you just may not know it. And you don't have to be an expert in psychiatry to provide emotional support. I'm not an expert in oncology, but I can provide enough information and support to cancer patients to help them make the best of a difficult journey. So, thanks again for allowing me to share this information.
Well, thanks for joining me today, Barb. I really appreciate it. It's been a pleasure. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.